I'll kick off. You're very welcome. And that was a lovely kind of introduction you gave. I'm just going to put up a couple of my credentials in the background here so you can see them. But and you know, some of the work that I've done, I've written a few books on mental health, and I've had kind of an increasing interest in trans issues and gender issues and ROGD and other related kind of concerns since 2017. And I did the film Trans Kids, It's Time to Talk in 2018. This is a picture of me when I was a kid. There's a reason why I'm providing this picture. It's not that I'm proud of my family. It's that when I was a kid, I had a very intense experience with gender. I was born in 1974, so it was a very different time. I don't know if you can guess which kid was me in that picture. It's the kid in the white t-shirt and the blue jeans. So I've kind of got a stripe, a blue and red stripe. So obviously I'm presenting very much as a boy there. I'm about 10 years of age. And it was my brother's confirmation. The reason why I put that up is to say that, yeah, I did have those gender issues, and I had them for many, many, many years. It goes back from the age of about 3 right through, and puberty was very, very difficult for me. And I wasn't celebrated. I wasn't encouraged. I wasn't dismissed. I was kind of let be myself, if you follow me, and follow my own road. And I did follow my own road, and I'm now a mother of 2 children, and I'm very glad I didn't transition. But I kept an interest in trans issues as a result of it, because I'd had such a long, intense experience of gender-related distress. It wasn't. I'm smiling in that picture. It wasn't fun. It was very distressing. I felt really alienated from myself, from my body. And when I look back, I often think I was misogynist. I hated girls. Hated everything to do with them. And yeah, I moved on from it, and I'm very comfortable. I'm very lucky to be comfortable in my own skin. These are a few organizations that I'm involved in that have sprung up in the last few years very much as a result of demand. And if anybody does want to know, further resources, contact Jen Specht, and we'll make sure to send you it. And we will be recording this talk, so it will be on YouTube. So to kind of get the talk kicked off, there are lots of different ways to treat gender dysphoria. In many ways, there's many ways into gender dysphoria. There's many ways out of gender dysphoria. For example, you can change your mind, so the individual's sense of gender can become aligned with their biological body. You can change your body. The individual's body can be altered to align with their sense of gender. And also you can learn to manage your distress, which is pretty classic, therapist kind of world. The individual's ability to cope with and manage their distress can be improved with a range of different approaches in relation to self-understanding, self-compassion, emotional regulation, behavior management, and distress tolerance. There's an exceptionalism often brought to gender as if it's like no other condition, when in many ways it is very, very similar to many different conditions that many clinicians would work with. Now, this is a simplified version of how a clinician might look at it. But sometimes the simple can kind of categorize your mind and clear things up, and it can be quite helpful. Now, I know Dr. Bell will be talking about this later on, but I just want to give a quick for anybody, because this is right at the beginning of the conference. I want to point this out. Like, trans isn't gender dysphoria, and gender dysphoria isn't ROGD. So trans is there's many different definitions of trans. One I personally prefer is this one, which is trans is an umbrella term to describe people whose gender is not the same as and doesn't sit comfortably with their biological sex. And it's not a diagnosis, it's a description of somebody. And very often it's a self-identified description. So I could identify as trans if I wished, and anybody can. Gender dysphoria is a very different thing. Gender dysphoria is a diagnosable mental health condition, and it's the psychological distress that results from an incongruence between a person's biological sex and their sense of identity. That could be what you would argue I had when I was a child. It wasn't called that because I had a different name, but that's very common in mental health. Conditions go through different terms depending on the context of the era. And so, yeah, gender-related distress is what I often call it. And it's a kind of a horrible feeling of, I shouldn't be this, I should be something else. I should be non-binary, I should be a man. And it feels very pervasive. and it's a very uncomfortable feeling. And then rapid onset gender dysphoria is a new phenomenon. Dr. Lisa Littman is here to talk about it. She noticed it, first of all, many people were noticing it, but she got the study out that, interviewed something like 257 parents and discussed what was happening to these adolescents. It's a new presentation that describes a phenomenon of adolescents who suddenly and rapidly experience a socially mediated expression of gender dysphoria. And so it has happened quickly. It's arrived out of nowhere. The most common question I'm asked is, where did all this come from? And I think Dr. Bell will be touching on that later on. Like, what has happened? It's not a diagnosis, it's a description of a phenomenon. So I just wanted to clear that up before we go any further. So like I said, Dr. Littman termed rapid onset gender dysphoria to describe a phenomenon of teenagers identifying as trans. I'm sure she'll probably flinch at my simplification of that, but you know what I mean? Sometimes you have to say, stay simple to get the message across, so she can clear it up later with more in-depth analysis. ROGD presents in young people quickly and intensely, and a key point for clinicians to know, usually after an extended amount of time spent online. It's the most common kind of factor that you hear about, and it seems to be the result of social contagion and or emotional distress. For example, in the UK, there's been a 5,337% rise in the numbers of female children presenting at the Tavistock. And so if you look at these two graphs, you'll see what is historically children who had gender-related distress were very small in number, were like people like myself, and it presented young. So for me, it goes back to as far back as I can go. So that'd be about the age of 3. And it's very intense and it's very loud. I remember Ken Zucker, who I hope is here, I know he registered today. Remember he said, when a child presents as, with gender dysphoria, the town knows it. It's loud, if you follow me. While ROGD seems to be a different phenomenon, it's not very young children. These are post-puberty, and it's generally after a long time online, and there generally seems to be some level of trauma attached. And you can see the numbers shot up as we became more online in the teens from 2012, 2013 onwards. It shot up fast. And if you look at the second graph, you will see that it shot up and girls suddenly presented. So historically, it was much more common among boys. I know I'm a girl, but it was much, much more common among boys. And there was 2 major cohorts. There was young children, who are boys most often, and middle-aged men. And suddenly, out of nowhere, adolescent girls came in very fast in kind of between 2012 to 2021. And it's an extraordinary change in the demographic. And not only that, their personality, their life experiences has changed. These are stats I've taken from Dr. Littman's study. 43% had a history of being isolated from their peers. 45% were engaging in self-harm prior to the ROGD kind of presentation. 48% had experienced a traumatic or stressful event prior to presenting with the ROGD. 63% had other diagnoses such as psychiatric disorders or neurodevelopmental disabilities. And so if you're a clinician working with this, you need to be aware of these facts so that you can work and be at your best and present so that you're not seeing gender dysphoria as an encapsulated condition. And you're aware 63% with rapid onset gender dysphoria that's presenting adolescents might have a psychiatric disorder. Certainly they did in this study, a psychiatric disorder or a neurodevelopmental disability. That would be things like ASD, ADHD, anxiety, eating disorders, OCD. And then 69% had social anxiety during adolescence. This is a vulnerable group. This is a very vulnerable group of young people. And so if you look at this is the common sequence of events for ROGD to be announced. Sometimes it's following a traumatic event. It's pretty much always after an extended amount of time spent online. Then the young person very often, not always, but very often identifies as gay, lesbian, or bi. And then after they've identified as that or some level of queer, they announce their transgender identification. Very, very often, this gender dysphoria that they kind of proclaim will be self-diagnosed, and it'll be via internet influences. They often know somebody either in real life or online or from TV they know somebody who has come out of as trans, and they are often very besotted with the kind of the trans politics, the trans kind of world, because it is very alluring. There's almost nothing more alluring in life than for somebody to say, you can be somebody different. You can be somebody different with a new name, a new identity, and you can get rid of the old identity and you can be a completely new person. For parents, gender dysphoria often feels like another diagnosis at the end of a long list, and we'll be hearing from our parent campaigner after me. Some common features in ROGD youth: they're often quirky, they're very likable, socially awkward, intelligent. I knew them as a teenager, you knew them as a teenager, that clever, quirky person, naive, vulnerable, very often heightened sensitivity and emotionality, hypervigilance around gender issues, very often online self-diagnosis and online influences, a politicized understanding of gender that would never have presented pre-2012 or so, a very much what's commonly I've noted as a clinician, and I work a lot in this field these days, the burden of privilege tends to weigh heavily on a lot of these young people. Not all of them, it's sometimes to give a talk, you have to give generalizations. They can be quite compliant and obedient until the day they announce trans identification. They can be a very obedient type who follows the rules and often hasn't found their strong voice, and they find their strong voice through a trans identification, socially mediated, as I've mentioned before, and conditions such as ASD, ADHD, OCD, anxiety, disordered eating patterns, and trauma. So they're common features. They're not always, I'm not saying they're always, I'm saying they're notable features. So as I said, key influencing factors would be things like anime, DeviantArt, Tumblr, Reddit, Discord, YouTube videos. Some of the YouTube videos are incredibly influential. The peer group, very often there's a cheerleading female friend groups. That might arrive after. They might have spent an awful lot of time online, and the female friend group might arrive after that are cheerleading. And they've found their world in a way. They can be very strong media influences. There's a huge glamorization of the trans identity, and which is great that we are kind of living in a world where everybody's accepted to be who they are. But it's very important that there's lots of ways to be edgy. There's lots of ways to be yourself, and that I'd love to live in a world where boys could wear dresses, where it's just not that big a deal. But at the moment, it does feel really quite confining, especially for boys with gender expression. It's very often well-meaning, encouraging, and I would argue quite misinformed adults. And LGBTQ workshops and seminars can sometimes bring about a very keen interest in gender, and that can move into a very strong online presence. And if you're a clinician working with ROGD, for starters, number one, you check out the tech use, check out the social media use, figure out. And I've found, with anybody I've worked with, they want to reduce their tech use. They want to reduce their social media use. They're well aware that they're overusing their tech, and they're well aware that it's a heavy influence. Very often there's complex pre-existing family dynamics in probably every family in the world, but working with the attachment and the family relationships can be very helpful in this context. Again, working with intergenerational or direct trauma can be very helpful, as a child who's trying to figure themselves out and who needs a bit of a hand in kind of processing their trauma. Biopsychosocial factors need to be brought. Like I said before, it's not an encapsulated condition. It needs a wider understanding. It can be very helpful for clinicians to work with the body, do some body work. Sasha Ayad is really, really good when she talks about that, the therapist who I work with on the Wider Lens podcast. And also their experiences of puberty. It can be very, very difficult for a girl to have puberty young, and they can often, maybe their breast develop very early. For a 9 or 10-year-old to manage periods is a really difficult challenge. I don't think it's given enough kind of attention. Just the whole logistics of trying to figure out how to manage periods and pads and leaking and all that. And I know none of you want to hear about it, but it's incredibly important that we highlight how difficult that can be. And puberty is getting earlier and earlier. And these girls are very young, and the emotional capacity to deal with the fact that your body, it looks very sexual at a young age is very difficult. Following on that, puberty arriving late for boys can be very difficult. It's a different experience, but it can be very difficult. The impact of co-occurring mental health difficulties, as I said before, ASD, ADHD, emotional distress. This is just very much what every clinician knows about. Regulation, self-compassion. Now, you would need to know things like issues pertaining to social transition. People are very, I would say, uninformed around what's the impact of social transition. That means the change of name, the change of pronoun, passing, the pros and cons of wanting to pass, breast binding, tucking, and things like that. It can be very helpful for the clinician to work with and explore conscious or unconscious homophobia and sexual development and attraction. And very often I've noticed in my own work that there seems to be a repression of their sexuality, a repression of their sexual development and their sexual attraction. And in its place, gender has kind of subsumed their sexuality. And that can be a very an interesting and challenging issue that could be approached. I want to point out that there is a difference between affirmation and confirmation, because a lot of people hear about the affirmative approach. There's no peer-reviewed long-term evidence base to support the affirmative therapeutic approach. It's a new approach, very much kind of in conjunction with the escalating numbers. WPATH released, their standards of care in 2012. And with that, the affirmative approach has kind of gained a lot of ground in the last 10 years. But many clinicians, including myself, believe that the affirmative model is necessary but not sufficient. You do affirm and support the young person as they learn to express themselves. You affirm your client's feelings, but that doesn't mean you confirm every thought or belief that they might have. And it's very seldom helpful to concretize every idea and belief an individual might have. So if you slip from affirming, which is affirming their emotions and affirming the level, the depth of their distress, and you move into confirming, you can inadvertently remove autonomy, you can impede the therapeutic process, and you can also get in the way of opportunities for therapeutic progress because you're confirming and you're concretizing perhaps something that might have been a more complex emotion. So in many ways, you could say clinicians are seeking understanding while adolescents are seeking identity. Adolescents should be seeking identity. That's developmentally appropriate. That is the time for adolescents to seek their identity. Erik Erikson did great work, the great Swiss and German psychologist, about identity formation in adolescence. And it's very well established that that's what we do. We put on different hats between the ages of around about 12 and 25, and we become those identities. We all did it. And you very much embody your identity as you're passing through, as you're figuring out who you are. And then when you've gone through the different phases, hopefully unimpeded, without kind of concretizing anything, when you hit your mid-20s or so, you find yourself, you know where you are, and you kind of know how to kind of go forward. So it's very important that we don't impede that kind of formation process by saying, this is your identity, go with it, concretize it, and safeguard it. I think freedom to move in and out of identities is quite important. Both parents and adolescents might seek the therapist, they very often do, and there is a significant lack of therapists who are working in this field. And the adolescent often seeks a confirmation, brand me, confirm my identity. And the parents are looking for a resolution, while the therapist is often seeking a deeper understanding of what's actually going on. I think we need to be careful that adolescents might use their identity as a shield to prevent further exploration. It's not a new concept. We've often seen it as clinicians, that sometimes the client can come in saying, I want to talk about this. And actually, as Fritz Perls said, what's going on and what's really going on. It's very, very common within the therapeutic context for somebody to come in looking for treatment about, should I leave my husband? And then a few weeks later, I'm talking about their alcoholism. Common, it's not unusual, but just we need to be aware that identity can be used as a shield. They might construct an imaginary identity online. It's very important that any clinician is aware of the online media influences. And they might repress their sexuality, and they might repress it within a gender identity. I do want to point out there's a very big difference between sexual orientation and gender identity. It's not the same as being gay or lesbian. It's a very different experience. It presents very differently. The DSM-5, which is, the kind of the clinician's manual for diagnosis, says gender identity is different from sexual orientation. Pronouns, names, and past personal histories don't need to be revised when a child comes out as gay. Being gay doesn't require active participation on the part of family, friends, and loved ones. If somebody's gay, you don't have to change their name. You don't have to think, what pronoun do I use? You don't have to do anything except, yeah, well done. Nothing is required from anybody else. Medical transition is not the same as coming out as gay. Why? Because medical transition carries a very heavy medical burden on the body. And so if you go from puberty blockers to cross-sex hormones, your fertility will be impacted. Your sexual functioning will be impacted. And I know, because I was that kid, I know that I couldn't have cared less. If somebody had said, you won't orgasm easily, I wouldn't have even heard them. I wouldn't have even cared. I wouldn't have even known what orgasm was. And I would have been very, very uneasy around sexuality and a development. I wouldn't have wanted to talk about it. Weirdly enough, I was told I was infertile when I was 25. And I was told I was infertile, and I couldn't care less. I didn't care. I was like, yeah, really, really. I didn't hear it, didn't care. By the time I was 32, I was like this, breastfeeding earth mother. I changed a lot in that time. And, I really didn't care when I was told that I could be infertile. And they were saying things like egg harvesting, and I can't even hear you. I just didn't care. I changed. So when a child says they don't care about their future sexuality or their future fertility, I don't think it is the responsible adult's role to listen to what the child is saying at that point. We listen, but we have to make sure that we remain as the adults in the room, and we make sure that we understand that sometimes a child can't quite conceptualize the impact of loss of fertility when they're 12. I want to talk a little bit about repression and shame. I love this picture. I love my trans body, because I think that is how trans could be a lovely way of being. You know what I mean? That they love their trans body, as opposed to, let's pretend I'm not trans. What about loving your trans body? Anyway, that's neither here nor there. As I say here, repression is a defense mechanism that this from Derek Russell. Derek Russell Davis, sorry, my mistake. Repression is a defense mechanism that ensures that what is unacceptable to the conscious mind and would, if recalled, arouse anxiety, is prevented from entering it. When we're repressing, we are preventing. We don't know we're preventing it coming in the door. So it's very difficult, and it's the job of therapists to work with repression, and it's complex. And so we need to be aware of things like internalized homophobia, internalized misogyny. These are big issues. Internalized misandry and stealth transition. These are all kind of, to me, something that every clinician should be aware of. An awful lot of people have come to me over the years, especially detransitioners, saying things like, I didn't want to be a butch lesbian. It was an awful idea. I wanted to be a boy instead. And so we need to be conscious of that. When you're working with somebody with ROGD, there can be a lot of guilt and self-loathing, a lot of, as I mentioned before, cultural alienation, the burden of privilege, middle-class guilt. These are often scoffed at, and I think they shouldn't be. I think we need to realize that there can be, and you're going to see some crazy words coming up here, shame at being internalized classism, being one of them, internalized classism, shame at being cis white middle class, very common, cisophobia, I think that might be my own or from Twitter. Oikophobia, I thought was quite interesting, which is the opposite of xenophobia, effectively hating of your own people, if you follow me. And then these are words people kind of came up on Twitter with me: internalized privilege phobia, faceophobia, which is kind of when you hate your own status and your position. You can smile at this, you know what I mean? And yet I would say it's very difficult to have the role of the oppressor in the world. And it creates a lot of complex challenges of, I'm in the oppressor class. I don't want to be in the oppressor class. How can I get out of the oppressor class? I don't want to be in it. And I'm so unhappy. How could I be privileged and lucky when I'm a deeply unhappy, really, really distressed person? I couldn't be in this privileged class. I couldn't be. So where do I go? And so we need to be conscious of this as clinicians. I think it's smiled at and dismissed too often. The tasks of adolescents, any clinician will know that these are just common or garden tasks that all adolescents need to kind of work through. We're trying to work through with independence, emotional maturity, develop their coping skills. And so every clinician who's working with ROGD needs to be aware that these adolescents need to work through these complex emotional experiences. They're, might need help with their peer relations, adjust to their body development, their sexual maturation, start to renegotiate relationships with their adults, and identify some meaningful moral standards, values, and belief systems. And, that lovely quote from Albert Ellis, from REBT, a different type of psychology. He says, there are 3 musts that hold us back. I must do well, you must treat me well, and the world must be easy. Is that it? I can't see it. And the world must be easy. Yeah, he calls it masturbating, which always makes me giggle. But yeah, this idea that we have to learn our limitations. Sadly, it's an integral part of healthy functioning. We are restricted by our time and our place of birth. We didn't create ourselves. We didn't choose our parents. We didn't choose our bodies. There's certain kind of limitations of our existence. It's part of being born that we need to kind of bring into some therapy with some people because it's helpful. And so, like I said, identity formation is a well-established process. It becomes heightened during adolescence, and so it should. It's neurotypical. It's not neurotypical. It's typical of development of that point between adolescence and maturity, that you become very heightened about your identity. And often adolescents develop an identity that reflects a sense of individuality that connects people to people in groups. And they can benefit from developing a positive identity within therapy if that's needed, to their gender, to their physical attributes, to their sexuality, to their ethnicity, to the birth circumstances. And sometimes a change in gender identity can manifest as a concrete physical solution to a psychic trauma. And it might lead to a belief that parts of the self can you discard, get rid of that bit. I don't want to be that. I want to be something else. I do think whenever you're working with ROGD, you need to be very aware that this comes in a social context, that there's an extraordinary level of celebration of trans identity. You can see I Am Jazz there, and that's from the latest I Am Jazz that will be out very soon. And also there's another trans kid, very well known in the media, Kai Shapley. And very often, the whole family become involved in the celebration. And while you could say that looks on the surface very positive, on another level, what would be my worry is that when you're over celebrating something, if I had been celebrated, I would have felt boxed and painted into a corner, because everybody would be cheering me on that I was this, and how would have I come out? And now, I'm lucky enough to have healthy sexual functioning and to have, I've had 2 children. I was very lucky that I didn't get channeled early or celebrated. Like I say, celebration can seem so great. And we all know the feeling of you're celebrated into something and you're kind of biting your lip thinking, well, yeah, but I've changed a little bit. And I don't know how to tell everybody I've changed a little bit. So what we need is a kind of a neutral kind of positive environment. So it's kind of neutrally positive. You're not too excited and you're not too focused on it. So they're just letting themselves be. Things like the Babysitters Club, on TV, in the novel, there was no references in the novels, no references to trans at all. And because of the new kind of phenomenon, suddenly it got inserted into it. So it is something that we need to be aware of. I want to give I'm coming towards the end quite soon, I will, but can you be born in the wrong body? Born in the wrong body is a great description of a person's feeling, but it is not a diagnosis. Using this phrase can lead naive youths to believe that they can have a different body, when in truth, they can only change the body that they already have. So it's a very, very, I would say, inappropriate phrase. You can only be born. I didn't have a choice of bodies to be born in. I was born in my body. That was part of the birthing process. And so to say you're born in the wrong body is letting very vulnerable, naive people to think, I can have an option. I can be somebody else. I can have a different body. You can have a different outward body, but you can't have a different inward body. It's not actually possible. And so we need to be aware of the kind of the intense social phenomenon and the social context that's happening here. This is a quote from Dr. Littman's study. It's just a very weird scenario around the numbers that Dr. Littman noticed. The expectant prevalence of transgender young adult individuals is 0.7%. Yet more than a third of the friendship groups described in this study had 50% or more of the adolescents or young adults in the group becoming transgender identified in a similar time frame. So that was a localized increase to more than 70 times the expected prevalence rate. And so it's a complicated stat, but it's a very important one. So if it's 0.7 of the population, and yet in these friendship groups, it was 70 times that stat, you're kind of going, well, something is happening. I'm not sure what's happening, but it certainly needs exploration. It needs thought. We need to think about this, because when something is 70 times the expected prevalence rate, something's going on, and it needs thought and exploration. So about social contagion, it's the spread of effect or behavior through a population. It's most always historically been most common among adolescent girls, and you're aware of the huge rises among adolescent girls in this cohort. Peer contagion is the process where peers mutually influence each other. It's associated with gender dysphoria and also with depressive symptoms such as disordered eating, aggression, bullying, drug use. Very often the risk factors among social contagion among groups, among peer groups, would be co-rumination, excessive empathy, repetitive discussion of an issue, excessive reassurance. You can just so imagine these gorgeous friend groups, kind of, excessive empathy and excessive reassurance and repetitive discussion, positive reinforcement, and competitive friendship cliques. So just to be aware of that. I do think clinicians have to be very careful around their language and their terminology. You need to take some time to learn the language, the terminology, and the acronyms so they're not a superficial obstacle to therapeutic progress. Defenses can manifest through a fixation on language, and I think it would be the role of the clinician not to allow that fixation to become an impediment to good therapy. A robust but understanding and flexible approach is often very necessary. Mistakes will be made. I'm a great believer in mistakes being made. The language and terminology involved in gender-related distress is constantly changing, but making mistakes provides valuable opportunities for a therapeutic process. So you don't need to be afraid of making a mistake because we are fallible humans. I want to point out about social transition requires a change of name, pronouns, clothes, hairstyle. It can be a therapeutic intervention that increases the likelihood of full medical transition. Ken Zucker did a great article on that in 2019. It can solidify, he mentions it and he describes it, can solidify and concretize the individual's perspective. And a depth perspective provides more insight for everybody. There isn't very much research. I shouldn't have said he wrote an article on it. There isn't very much research on social transition. We need masses more research on this phenomenon before we can figure out where we're going with it. I would say it's a very distinct psychosocial intervention. It shouldn't be undertaken without clinical supervision. It shouldn't be undertaken lightly. It's never been undertaken before. Never before have we heard of it's, I'll put aside like freakishly tiny, vanishingly rare numbers. Children changing pronouns. This is new. This has not been done before. And so if you're part of a process that's undertaken to change names and pronouns, be aware there is no research long-term about this. We don't know what is the impact of that. A compassionate, curious, and flexible approach towards the use of young persons' names and pronouns can be helpful. I'm personally very for a compassionate, curious, and flexible approach to most distress. Just towards the end of this talk, I want to talk a little bit about suicide because there's an awful lot of talk around suicide with this. There's very little peer-reviewed evidence about suicidality and gender dysphoria, but the Tavistock does report, and the Tavistock, Dr. Bell will talk about it later on, but it is the largest gender clinic for the NHS in the UK. They report, and this is a quote, that it's extremely rare among children expressing gender distress. The risk of suicide among gender dysphoric youth seems to be similar to the risk of suicide with other mental health challenges, such as anxiety, OCD, depression. The risk of suicide remains post-affirmation and or medical transition. So people have this misinformed view that if you affirm or if you medically transition, that it will change the risk of suicide. That hasn't been shown to be the case. The research is very paltry anyway, but one research I do know is that, I don't know how to pronounce the name, Dejna, from 2011. It's a long-term follow-up of trans people, and it was taking place in Sweden. It was over about 40 years, and they noted that post-medical transition, that there was a dip, usually around about 10 years later, but that there was the post-medical transition person was 19 times more likely to die by suicide than the general population. And so that is an issue that we need to be very aware of. Now, that the general population haven't got a diagnosable condition that these trans people might have, so already it's complicated numbers, but they are shocking numbers. 19 times more likely is a definite something that we have to be aware of. Personality disorders, psychosis, schizophrenia, drug dependence, they carry the highest risk of suicide. So please be aware, what are the comorbidities? What are the co-occurring issues that might be presenting with the person you're working with? Suicidality is sometimes linked to the wish of getting rid of aspects of yourself. This is Dr. Laura Edwards Leeper. She's the chair of the adolescent and children section of WPATH, which is the World Professional Association of Transgender Health. And she said recently, very recently, as far as I know, there are no studies that say if we don't start these kids immediately on hormones when they say they want them, that they're going to commit suicide. So that is misguided. In terms of needing to intervene medically to prevent suicide and doing it quickly, I know of no studies that have shown that. That's Dr. Edwards Leeper. So we need to be very careful about how we talk about suicide when there actually is no real representation. There's been an awful lot of misinformed myths around suicidality and gender, and it needs to be cleared up, because suicide is such a difficult topic. It's such a terrible tragedy when it happens. Families are devastated by it. And that's why we need very accurate analysis and very accurate information about who is suicidal, who is at risk, what should we do about it. We need to stay really rigidly into a very good, accurate analysis when it's something as serious as this. So this is a national report from Sweden, just released earlier this year, or else just late last year. It was quite recent anyway. And what it is it compared basically suicide mortality, people who died from suicide with different conditions. And as you'll see, the yellow is women and the orange is men. And you'll see the different kind of rates. Personality disorder was the highest, schizophrenia, harmful use and drug dependence, bipolar, depression. You'll see gender dysphoria and autism. You can see there's a spike there with gender dysphoria for women and men. I often wonder about the impact of testosterone. This is just an aside. I often wonder about the impact of testosterone on a female, because traditionally males are more likely to die by suicide. So suicidality covers suicidal ideation, which means thoughts about taking your own life, and it also covers plans and suicide attempts. Suicide plans and attempts tend to be more common among females. Suicide itself tends to be more common from males. And suicide contagion is a very real risk, and it's triggered by exposure to suicide or suicidal behavior. And often the way we speak about suicide is incredibly powerful. And so, they created these guidelines in 1989 about suicidality and how the media needed to talk about suicide. And when Kurt Cobain from Nirvana died in the early 90s, the media were very, very good in reporting, because they had the guidelines and they were very assiduous in following them. And then many years later, and there wasn't many deaths as a result of that terrible tragedy. Many years later, sorry, I'll just finish there. Robin Williams died by suicide, and we've become sloppy. We've become sloppy because of social media. And so this kind of adherence to the media guidelines around speaking about suicide got thrown out the window. And there was a huge contagious effect after the death of Robin Williams because of the media. The general consensus is because of how the media portrayed this. We need to be really careful around it. And I just think it's very important to kind of really drive that point home. And the clinician does need to, I am finishing now, I'm sure you're rolling your eyes by now, but just coming to the end, we do need to manage unrealistic expectations as clinicians. Some young and vulnerable people, they think they can fully change sex. They can fully embody the other person. So I remember speaking with one person, and they thought by taking testosterone, the impact of, let's say, breast cancer, or the impact they didn't have the same risk factors of females anymore because they were now male. And so when I said, well, the impact of testosterone on the female body is very harsh, they said, oh no, but I'll be male, so it won't be hard on me. And that to me was somebody who needed more information about the reality of their actual biological functioning inside their body. Clinicians need to inform themselves and the young person about the realities of medical transition, so they can fully inform the young person about what to expect about the burden of medical transition. Addressing issues such as gender role stereotypes can liberate the young person from feeling the need to conform to society's gendered expectation. Therapy for the young person can be painful work, and therapists and parents should be empathetic, patient, aware of the relapse cycle, respectful of the young person's defenses. This is a diverse experience. Sexuality, ROGD, trauma, comorbidity, they're all complex issues. They affect a diversity of people in a diversity of ways. It requires sensitive debate, which I hope we're going to have today. One person's experience doesn't negate another person's. Diversity shouldn't imply fragility. We each have an obligation to question our assumptions, our opinions, our ideas, and we should be able to do it with the robustness of spirit. So I hope you found this talk helpful. We do have resources. If you look on GenSpect, that's the place to go if you want to hear further kind of information about this talk and about any resources. Thank you very much.